This meeting is now being recorded.
Well, again, good evening. Welcome to the EDS Awareness Educational Series webinar. My name is John Furman. Before we start and introduce our speaker, we'd like to give you an overview of our free program for those attending for the first time. So we'll go over who we are, what is our program, upcoming events, introduce Dr. Mark Lavallee, and then we'll have a Q&A. So again, my name is John Furman. I manage the National EDS Awareness Program based in Cincinnati, Ohio. My daughter, Deanna, leads the Cleveland, Ohio EDS support group. She was diagnosed with EDS in 2008, the same year my wife passed away with breast cancer. I was a caregiver for my wife who struggled with undiagnosed EDS for over 30 years. So we introduced our programs in 2012 at the EDNF conference to help EDSers form independent local support groups and spread EDS awareness in their communities. We've started over 70 groups to date. Each group is given their own free website with a link to the directory and map. We receive feedback that conferences provide valuable information and social opportunities that many cannot afford physically or financially to attend in person. So we decided to bring the speakers to you through the free EDS Awareness Educational Series. We meet every first and third Tuesday, typically at 7:30 p.m. Eastern Standard Time. All the programs are free. The meeting announcements and whenever possible, the webinar recordings will be posted on our website at edsawareness.com for later replay. You can receive email announcements for future sessions by requesting the free report on our site. Tonight's presentation is sponsored by Body Support Store, where you'll find over 250 products selected by EDSers for EDSers. The store is the only funding for the program and usually covers our monthly web fees. Please visit our store and check out the helpful products that we sell. So just a general disclaimer, this presentation contains general information about EDS. Members of the EDS community voluntarily participate in this program. The information is not advice. If you are having medical problems now, please call 911 and always consult your doctor before making any changes to your treatment.
Our upcoming events, we are having webinars twice a month, and next month in March it's going to be the 17th, and that's Cynthia Allen, who's presenting the Feldenkrais method to improve function and ease. And then next month in April on the 7th, we're going to have Dr. Forrest Tennant, who's going to talk about intractable pain, centralized pain in EDS. Just wanted to remind the people that are attending live there will be an opportunity for Q&A after the presentation. Add your questions at any time during the presentation by clicking the Q&A icon at the top of your screen. After typing in your question, click the orange button to submit. Our speaker tonight is Dr. Mark Lavallee, and he will talk about exercise being medicine for EDS, and he knows a lot about that. I have a long list of accomplishments and things that he's involved with, and I had to kind of truncate this, so I'll try to go through the major highlights. He practices in York, Pennsylvania, and he's a fellow of the American College of Sports Medicine and the current director of the York Hospital Sports Medicine Fellowship at WellSpan. Previously, most of you know, he was the medical co-director at the South Bend Notre Dame Sports Medicine Fellowship That was from 1999 to 2013. He was the head team physician for Indiana University South Bend and University of Notre Dame men's soccer team. He has also been involved with being a team physician and chairman for USA Weightlifting, medical director for several events, including the World Masters Weightlifting Championships, Olympic team trials, and U.S. Fencing National Championships. In his current role, he also has faculty appointment as assistant clinical professor to Penn State and Drexel University School of Medicine. Moving on to his Ehlers-Danlos expertise, as most of you know, he does have EDS classical type, and he joined the EDNF in 1987 and served on their board of directors from 2000 to 2005. He is still serving on the Professional Advisory Network, and he has been a speaker at many of the national conferences, authored numerous papers and book chapters on sports medicine. He is co-investigating with the NIH on a study looking at EDS and Marfan's with Dr. McDonnell, and he is currently part of the AMSSM task force with the National Marfan Foundation regarding guidelines of diagnosis and activity recommendations. And just to note that in his current role, he has a ADS clinic, which covers multiple specialties, including cardiology, orthopedics, physical therapy, pain management, and exercise physiology. I didn't cover everything, but just to give you a sampling of things that he's involved with, and I wanted to extend a very warm welcome to Dr. Lavallee. We're looking forward to hearing from you, and you will see your slides are going to be loading on the screen momentarily. I'm going to go ahead and turn over the microphone to you.
Okay, thank you, Deanna. Thank you,
Thank
John.
you.
I think it's awesome what you guys have done, and I want to show my age here because at some of the very first EDNS conferences back in the 80s, we would all gather together in different, in Chesapeake, Virginia. Pat Malenfant, good friend who's listening today, got to meet them and some other people. I'm seeing names pop up, and many of the names I recognize. So to all of you out there, thank you for taking an evening and listening to me stand on my soapbox. And I'm very passionate about Ehlers-Danlos Syndrome. Yes, I do have it. I've experienced a lot of what you as patients have experienced. My journey is probably not too different than your journey, except I'm now a physician. And we may have some physicians that have joined the group with EDS, so I welcome you to get involved and try to make a difference in other people's lives. So I'm going to try to move things along. I got a bunch of different screens here I'm going to try to navigate through. Let's see if I can do this. There we go. So, nope, wrong way. There we go. Okay, so is everything, I have no conflicts of interest other than I have EDS, which I guess could be a huge conflict of interest depending on if you're used to hearing people that don't have EDS talk to you. So that's one conflict. And I have a couple cases here where patients have given me permission to use their stories over the years. I have blacked out their eyes, so you might not know who they are. Some of you may know who they are. So we're not going to talk about one of my favorite topics, which is weightlifting injuries, as if you look at these gory slides. EDS people dislocate. They just don't dislocate when they're clean and jerking 200 kilos over their head. We're not going to talk about football injuries, which we deal with. But we are going to talk about EDS. And, not all hyperflexible athletes have a connective tissue disorder, and not all patients with connective tissue disorders are pathologically flexible. Okay? The interesting thing that I found is not everybody with EDS is double jointed in all of their joints. And we will deal with certain joints that are problematic and other joints that are really stiff and tight. And working with physical therapy and my team, we can usually figure out that some people who are really loose in certain parts of their body are really compensating tight in the others, and we need to address both. Okay. So I'm going to fly through about 47 slides here. So just a quick overview. Why do we have problems with the EDS? It goes back to collagen, which is a triple helix. So if you think of a piece of rope, the difference between our collagen and everyone else's collagen is that when it's made in the cell called a fibroblast, it's processed. It's processed by the nucleus into the cytoplasm and out into the real world. Most people have different enzymes that sort of cleave the end and make it sort of like the rope looks like a nice melted or whipped piece of rope. If you've ever had a piece of rope and you cut it, it starts to unravel. Okay, you can imagine that's what our collagen looks like. Our collagen looks like sort of unraveling rope. And when you stack pieces of rope that are unraveled together, they don't stack as nice as nice clean cut pieces of rope. And that's why the collagen in EDS is not as strong. Okay, major types of collagen, type 1 and 2, type 3. Depending on what type of collagen is affected will depend on your expressivity and the problems you have. I'm not going to spend much time on things like Ehlers-Danlos Syndrome, which is sort of relatively new on the scene in the last 10 years, which has all the fun of Marfans and all the fun of EDS sort of rolled into a combined TGF-beta receptor 1 and 2 variant. Haldiz is just down the road here in Hopkins. So a lot of neat things from a genetic standpoint. But I always think we need to start with history. History teaches us a lot. And just a few slides about EDS. Back in 1682, this is sort of the first lithograph that they relate to EDS, because this gentleman with a really cool Spanish mustache could pull his skin off his chest. Okay, and this is by a surgeon by the name of Van Mierken. And we're not 100% sure because obviously it's just a lithograph. You go to Kopp in 88, 100 years later, and then Chernigov, which was a Russian dermatologist, and they still call this Ehlers-Danlos Syndrome or disease in Russia in many places, because he was the real first one to sort of describe it. My two good friends, Evard Ehlers and Ehlers-Danlos, and you can see that they lived to the early 1900s, real snappy dresser type of guys. But here's the first known picture in 1908, so this is just 107 years ago. And if you notice this picture, I don't know if you can see my mouse, but you can see him pulling his skin up here. You can also see his elbow is dislocated with his elbow pointing forward and his hand pointing backwards. Okay, and obviously he's not an extremis and he can auto-dislocate. So this may be the first known case of picture of Ehlers-Danlos. Now, what does the World Weightlifting Championships and EDS have in common? I found this out by absolute accident. Of all the places that I get to go with weightlifting, I was in Copenhagen this last fall in September. And every day we'd walk from the hotel to the venue site. And here you can see my medical team, my fellows, my resident, my athletic trainer. You can see the venue, which was really a team handball venue that they converted to a weightlifting venue. I always like to get exercise, so I walked 2 miles or so to the venue each day and back again. Well, I started realizing as I prepared for another talk on EDS about where Evard Ehlers was from Copenhagen. I'm like, well, gosh darn it, if he's from Copenhagen, I wonder how close I am to the hospital that we sort of found the first case of EDS. Well, I walked by it every single day for 8 days. So it's now Amagar Hospital, which was formerly Frederickson Hospital, and it's now a psych hospital, so that tells you something. So it started off as a general hospital, it's now a psych hospital. Walked by it every day for 8 days, didn't find it to day 7. So, interesting tidbit. So in 1949, Ehlers-Danlos was given its former name. It wasn't until 1955 that there was known as there was a genetic defect, collagen defect. We didn't know how it was transmitted until Peter Beighton out of South Africa in 1968. EDNF was founded in 1985. The new nosology was done in 1998. We still have people that refer to the Roman numeral type nosology, which has not been the standard of care for 16 years. So very, very interesting. Victor McKusick, who's considered the sort of the Mendelian inheritance of man, sort of the father of medical genetics, got the prestigious Japan Award in medical genetics and genomics in 2008 before he died at 97 years of age. He was at Hopkins. And I had the pleasure of meeting this man. Who actually was quite a neat man. He diagnosed me when I was a fifth grader. And I remember specifically telling my parents, do not let him do gym. Do not let him exercise. Whatever you do, don't let him ever lift his hands over his head. And please don't let him ride a horse. Which I find hilarious because I was a suburban kid and never had the inkling to ride a horse or do much overhead. But golly, once you're told as a fifth grader what you can't do, all of a sudden it gets really interesting. I was really jonesing to find out what's so, scary about riding a horse and why can't I do it. And I started trying to play tennis because I knew that was over my head. Not really great for a young male that dislocated his right shoulder 20 times before I turned 20 and my left shoulder 13 times before I was 20. So I was, for someone with classical type EDS, I had a tremendous amount of laxity issues. So let's talk about some famous people with EDS. Sorry, I just had to close the door. One of my teenagers was listening to music. The first is Nicholas. Well, that didn't work out too good. There's a whole bunch of pictures. Nicholas Paganini here in the corner was a virtuoso violinist who's called the devil incarnate because he could achieve sounds on his Stradivarius that no one else could, so the other musicians said he must be possessed by the devil. Death mask and hand cast at his funeral showed that he's not a arachnidactyly but had some arthritis in his fingers and did not look Marfanoid, so there was some question if he had it. The rubber men of India were actually not rubber men of India, they were rubber men from Romania. And then there's some question about Pia Zadora possibly having, she was an actress from the 1980s. The incidence, as you can see, has changed from 1 in 20,000 live births to 1 in 2,500. And the reason is not because people with EDS are reproducing like rabbits. It's because of relatively mild cases were going underdiagnosed. Now people in medical school are learning about this more rapidly. Actually, the ease of medical information through smartphones, iPads, and electronics has really been able to help people make the diagnosis much sooner. So we all know what Ehlers-Danlos Syndrome is, and there's just there's just a lot of things with skin hypersensibility, hypermobile joints, bruising, and skin fragility. So I want to go to a research project that I started over 15 years ago. And I really had this question because I started to see a trend with people coming to my office. I'm like, I didn't really advertise that I had EDS, never really did. People sort of found me. But I also started all these patients that had no idea what EDS were showing up in my musculoskeletal orthopedic clinic. So I sent out, over 15 years ago, I sent out 1,440 questionnaires and got a pretty decent response rate. It was basically, do EDS patients exercise? And as you can guess, the answer is yes. I had a 13% response rate. Now, granted, it was mostly women, which is not uncommon for women to be more responsive to surveys than men. It has nothing to do with this being an excellent trait. So as you can see, the respondents we had about 7% vascular, a quarter classical, and 50% hypermobile, which also, in my clinical practice, correlates with about the split I see. I probably see one for every eight or nine patients I see that are classical or hypermobile, I'll see one vascular type. And then hypermobile is the most common thing I see. So what are these, here's the age range of my respondents, 5 to 75 years old. 17% actually swam in high school or college or recreational. A quarter exercised every day. Almost half exercised 2 to 4 times a week. And then only 16% did no exercise. So I found this extraordinarily interesting that even those people with known EDS were active either prior or were actually currently active. So what factors determine, flexibility? Well, there's a couple things, genetics. And I don't mean genetics as in you got EDS and you're loose. I mean, like, look at your mom and your dad, okay? If they don't have EDS, their flexibility will probably be tied into your flexibility, irregardless of EDS. Now you add EDS in there, and if you got it from mom or dad, that's going to be affected. But just like I found, is that just because people have EDS, it doesn't mean they're all loose all over the place. Now, yes, there are some patients that have that, but not everybody. Okay, how much stretching you do, how much manipulation you get, muscular mass. Those that have good muscle mass do so much better. And I've learned this over the last almost 20 years of clinical practice, and will be the sort of the foundation of what I'm going to be talking about today. The age, you know, ladies between 15 and 25 seem to struggle the most with this condition. Then they start to improve at around 25. And then, of course, any sort of collagen defect you have. I was blessed to be able to work on the Human Genome Project in Roger Lotta's lab at Penn State Hershey back in the early 90s, actually 91, and we found the loci where the COL3A1 gene is, which is the vascular type. So I actually had the opportunity to be in a lab where we worked on our, you know, I don't have vascular type, but I was working on EDS, which I found very rewarding. So what can you do? Okay, yes, this is a picture of me a couple years ago, many years ago actually, but just because you have EDS doesn't mean you can't do amazing things with your body, okay? And this was when I was at the local training center back in the 90s. So you can do just about whatever you want, you just have to have the mind power. And pain is something I'm going to teach you is not the limit, okay? You can blow through pain. Pain is, you know, any Olympic athlete, Lance Armstrong, before all the hullabaloo about his doping, I mean, could ride through an amazing amount of pain more than any other human I know. And it was just amazing what he could achieve, which would have knocked any other cyclist or athlete down. He could keep going when he became anaerobic at you know, climbing in some of the mountain climbs he had to do in France. And I'm not a big fan of Lance Armstrong, but I'm just telling you the pain is in your brain, and I'm going to teach you some tricks of how to deal with that. So there's things you can do. Anybody that's seen me will know that I'm very much into strength training. And we're not talking about looking like Kendrick Ferris, who went to the Summer Olympic Games, or Chad Vaughn. We're talking about simple core strength, daily exercise, stuff with your body weight. You don't need to have an expensive gym membership. Most of my patients, I want them to hold on to the back of a chair and do body weight knee bends. And they go, well, my knees hurt. I'm like, yes, they will. But if it hurts now when you weigh 250 pounds, imagine what those knees are going to feel like when you're 270 and you're 10 years older, or 300 and you're 20 years older. So it ain't going to get better, and it ain't going to get better if you're sitting down. We've got to get you moving. And I've heard every excuse in the book, and I'll tell you some of my better excuses here in a bit. So, you know, resistance band, dumbbells, barbells, machines, any of those, what I'm going to tell you, probably stay away from. And I don't mean these against CrossFit. You know, I love CrossFit for my regular patients. They definitely get injured a lot. I don't think it's the right venue for those with EDS. You know, maybe there's some that can, you know, get, if you're in great shape, we can talk later offline, or you can ask me questions. Olympic lifts, you know, if you're already dislocating your shoulder, you probably shouldn't be doing this. So, you know, what else can you do? Cardio training. You got, you know, just because you have EDS doesn't mean you're eventually not going to have heart disease or diabetes. It's America. Wake up, guys. You know, we love our junk food. We love, you know, eating more than we should. So, you know, was it over 50% of America is overweight now? Well, imagine, you know, what I always tell people is a person with EDS is like a truck, okay? And if, you know, if you're a truck and I loosen all your lug nuts, it's basically like the replicating like you have, you know, a loose joint. And then if I take that truck and I add 3,000 pounds of payload in the back, that's someone being overweight. Well, what's going to happen? You're going to wear out those tires quicker, okay? They're going to be less effective. So my goal is offload the bed of your truck, tighten up your lug nut, and you'll drive better longer, okay? Because there's no connective tissue cure yet. There's some things on the horizon that we're hoping to get, but not right currently. So you need to keep in shape. And, you know, walking 10,000 steps a day is the recommendation by American College of Sports Medicine, American Academy of Family Practice, American Board of Internal Medicine. Swimming is very good on the joints. And you can say, well, I dislocated. Well, so did I. I remember when I was in 6th grade at swim team meet, during a swim meet, I dislocated my right shoulder, sunk down to the bottom of the pool. Much to the dismay of my parents who were watching me, hoping I was normal. The next their kid is in the bottom of the pool. I walked over, grabbed my shoulder, my hand out of the ladder, and I popped my shoulder and it came out from the bottom. Never finished the swim. But did that stop me? No. You get back on your bike again. You do it again. Not that day, of course. Treadmill, walking on a treadmill incline, stationary bike, ergometer, which is a rowing machine. All these are great, great things to do. I don't recommend distance running. Running half marathons and marathons is just a lot of pounding that the joints with EDS don't do well with. Core strength, flexibility, balance. You're going, what does flexibility have to do with EDS? Trust me when I say, the hamstrings of many patients with EDS are tight. They overcompensate. We have to work on it. Having a TheraBall, which is a therapy ball, yoga, Tai Chi, FMS is function movement screening. We use all this for a regular athlete. Trust me, this is what we do for the athletes that are worth millions of dollars. The ones at Division I colleges, my Olympic athletes. I'm teaching you these are the secrets that we can help you. And many of you probably done this with your physical therapy caregivers. What I highly recommend not doing is competitive cheer, gymnastics, some competitive swimming, all because those, and figure skating. All of those really auto-select for the double-jointed or hypermobile athlete. And the problem is that once you become competitive, that's when the problem begins. You can do gymnastics, just don't compete. It's a competition, the 3 hours a day, 7 days a week, that you need to be competitive. It just wears out the EDS body so quickly. So here's my sort of overview. Just do it, okay? Don't feel sorry for yourself. I've heard it all. And I would probably say most of you have better hands and better back and more digits than I do, and I'm a doctor. So I've heard it all. Now, there's probably some of you out there, like my veterans, who are missing arms and legs. But you know what? Be thankful to God that you have arms and legs. Be thankful to God that you have arms and legs. Because you know what? You can actually feel pain. Some of these people have no legs, and they feel pain. Imagine that. Imagine having all the pain you have, but nothing's a rub. No pill's going to make phantom pain go away. Okay? If you feel bad, think about the baby with retinoblastoma that I had just last week, whose parents are watching her die. Okay? Look at your kids tonight and realize you're going to get to see them, another day, another week. Maybe grow up. Okay? You're going to be able to hold your loved one. So when you feel bad about yourself and the lot that you're given, think about some of the patients that I get to see. And it makes it a lot easier for me to tell patients, hey, you know what, you can feel sorry for yourself for an hour a week. More than that, you know what, we live in America. If I talk to any of you guys in a third world country, which I've been in India, I've been in Asia, you know what, there is no Social Security. You guys would all be in the rice fields picking whatever and doing like everything else. We live in a great country. Don't forget that. We have our problems. But another thing is a big issue is I made this mistake 15 years ago, giving narcotics to my patients with EDS. Huge problem, huge problem. Yes, they work. Not saying they don't. But daily narcotics is a huge problem for anybody with EDS. Yes, I know it takes your pain away, but you're robbing Peter to pay Paul. Your body will become dependent on it. You'll need more of it. And this is definitely my soapbox, and I'm sure many of you on it are on narcotics. But, I've seen thousands of people with EDS, thousands. Okay? I've tried to get all of them off daily narcotics. Do narcotics play a role with EDS? Possibly. For when you have flares for no more than 3 days in a row, no more than once or twice a month. That's the role. And I've had to detox many of the patients that I started on chronic narcotics. So that was my penance, to get them off of that. And I pretty much tried to get all but a handful of patients I got off the medicines I started, because I believe I was part of the problem by giving them those medicines. Exercise every day unless. I only have two things there. A, you're having surgery that day, or B, you have a temperature of 101. Okay? There's no other excuse. There's very few excuses. Okay, well, maybe it's you lost a loved one and you're set. But you know what? I don't ask anybody, any of my patients, to do anything that I haven't tried myself. I'll say that again, okay? I've had executives say, Lydia, if I don't have time, I said, well, make time. Well, I don't have time. Make time. Sleep less. Go to bed earlier. Carve out time. Well, I'm busy. I'm a mom. I've got kids. Make time. If mom ain't happy, no one's going to be happy. Laugh every day. Find the joy in life. Just because you're in pain, just because you're suffering, doesn't mean you cannot have joy. Okay? Watch a sitcom, read a joke book, hang out with people that will build you up, that will tell you jokes. Because laughter releases all sorts of endorphins and enkephalins that help combat pain. And lastly, help people that are less fortunate than you. So whatever your religious background is, whatever it is, when you truly help others and you give of yourself, there is such a reward that goes untold. Okay, goes untold on how it can help you. And there's a book when you think that it's all a craft, that Dr. Lavallee doesn't know what pain is. Read this book. I make every single doctor that I've trained. I've trained 34 fellows in sports medicine. Everyone that gets a copy of this book and must read it, because 95% when people come to my practice, athlete or not, is because they're in pain. Physical, psychological, neurologic, doesn't make a difference. They come because they want help with their pain. Read this book. It will open your eyes, because pain is beautiful. If you don't have pain, not good. Okay, not good. We amputated a kid, a 40-year-old's leg, diabetic, not Ehlers-Danlos, because he didn't feel the nail he stepped on. He's diabetic, and he got infected. He got gangrene. He had to cut his leg off, the lower part of his leg off, because he couldn't feel pain. Leprosy, and this book basically talks about leprosy in India. But if you have a chance, I would encourage it. Lastly, is you need to set goals for yourself. If you're just existing, life will never change. Life will never change. It'll be the same day over and over again. Groundhog Day over and over. Goals. Set some realistic and set spectacular goals for yourself. Spectacular. Think about the things that you would never believe you could do, because that's what I did. I was told over and over again what I wasn't going to be in high school. I was told I shouldn't be a doctor. I was told in medical school that I wasn't going to live long enough to get through residency. Okay? If I had listened to those people, I would have given up. Okay? God has blessed me many times over, and I want to share that with you, that journey with you. So case number one, I call Hong Kong Fooey. 34-year martial artist, world champion, multiple joint complaints. Okay, loose joints, mild and loose joints, maternal aunt, 7 state titles, 3 national titles, 1 world championship gold medal, Hall of Fame, has EDS. He set spectacular goals for himself. His EDS was helpful. Okay, he could achieve movements that his other opponents couldn't block because he was double jointed. Okay, he used his EDS as an advantage. Case number 2, I call Stretch Armstrong, 15-year-old wrestler. This dude is built. He's got muscles all over the place. He's had 5 dislocations from shoulder pain, but he controlled his dislocations because he had good muscle mass. Okay, he could move his fingers back. And 3, swimmer. Because he could overly rotate his forearm forward, he had a longer reach than his competitors and won not 1 but 2 state championships in Indiana. Okay? He was very, very flexible. Okay? Case 4, recreational athlete who was a cyclist, fell and struck his abdomen in a bike like many people that wreck. Just so happened he went to the ER and they got this x-ray, which shows here a large aortic aneurysm. He was soon diagnosed with vascular type EDS, and they took care of him. So in conclusion, and wrapping up my talk today, some recommendations. Consider physical therapy. Most people do, but there's some very important things. It's not just going to your local therapist that's closest to your house, or what, you have to seek out really good a manual therapist that will work with your stretching and strengthening, proprioception or balance training, strengthening kinetic chain, doing the functional movement screening training, you want to avoid contact inclusion sports and high dynamic sports. I encourage low static and low to mild dynamic exercise. Okay, these are things like biking, swimming, mild weight training, and golf. Patients often excel in certain sports such as, where their genetics are easy. They can, like, ballet. I had a young lady, 10 years old today, probably has EDS, who's already on point in ballet way too early, having problems with crushing some of her growth plates because she was put on point too early. But she probably has EDS. But I got to talk to the program director, their troop director first, to get her off point, and then we can deal with some of the genetic components. Figure skating, gymnastics, swimming, wrestling, all people that are double jointed do well, and so you have to be very careful in allowing them to do those sports. I believe everybody should be screened, whether you've got vascular type or not, for valvular issues with an echo and an ultrasound of the aorta. Why? Because there was a great article that came out in 2001 by Rick Weinstrup out of the Children's Hospital Cincinnati, which showed that 22% of those with hypermobile will have an aneurysm of the aorta in their lifetime. 22%, 1 in 5. Vascular type, 95% chance of aortic dilatation. Not necessarily rupture, but dilatation in possible aneurysm. And then classical type, which is what I have, is 35%. Those are the numbers, people. So you might as well get screened. Most people get screened, and people know that, but we still fight insurances that don't understand that, there is no genetic test right now for hypermobile type, yet they have a 1 in 5 chance of getting an aneurysm. So it's over the whole lifespan. It's not, and we can do a lot of amazing things interventionally now that we didn't have just 10 years ago. Endoscopic deployment and sleeves, external sleeves for aneurysms, just amazing things they can do without cutting people open as much as they used to. 3 to 5 years, get these tests done, and if after pregnancy, we check some things. So basically, wound closure for vascular type, I like Dermabond and Steri-Strip spreads and sutures. There's a whole bunch of lectures I give on reproductive concerns with affected mom, non-affected fetus, affected fetus, non-affected mom, or affected fetus and mom. I think the psychological support is probably what I spend the most time doing, is telling them it's going to be okay, that I'm going to give them permission to have a life, and we're going to get them to have that life. We're going to get rid of their wheelchairs. We're going to get rid of their braces. I said, if you give me a year of your life, we'll change it. You will not recognize yourself. And then I try to use surgery as a last resort. We do get that. I mean, even I've had surgery. So I'm not anti-surgery in the sense of I just hold it off as long as we can. We have specific protocols. Most orthopedic surgeons do not understand the tissue fragility. We have different protocols in the operating room, so they do not, especially with more and more stuff being done arthroscopically through the scope. Finally, I always keep the EDS in the differential that any of my hypermobile athletes show up. Still, as 2015, it should be diagnosis made through exam and history, beware of certain sports. And sometimes athletes, despite less than optimal genetics, can succeed if they work hard enough. Thank you very much. And at this point, that is, I believe, the end. There's some references there. That's the end of my talk.
Okay, thank you for your talk. You will be able to see some of the questions in the Q&A box. If you click on the top of your screen, it should open up that list for you.
Okay. Okay. Okay, question 1 from, can I mention who they're from, or should I just, probably not, I guess.
Oh, yeah, you can use the first name if you'd like. Okay,
from Fran, the impression from the NIH study with Dr. McDonald was closed. Yeah, it is closed. I haven't conversed with Natalie for a couple of years, and that has been closed. You're a fourth-year medical student, about ready to graduate, going to orthopedics. Advice for how to cope with the rigors of residency training. Let's see, particularly my free time, about to get sparse. Okay, I'll tell you a trick that I did for this next question. Biggest problem is joint pain and stability, leading to 8 orthopedic surgeries in 10 years. Okay, Okay, so Lisa asked the question, she's a medical student. Okay, I'm going to tell you what I did, and I'm not going to, whether it's right or wrong, it's how I live my life. So one day I was on, this is back in the day when there was no restriction on the amount of hours you could work. So there's only 172 hours in a week, and I think my worst week on residency in the 90s was I worked 160 hours in a week. So I only went home for 12 hours just to get mail and do some laundry. So I worked, and I was exhausted one day, and an upper year resident said, Lavallee, what are you doing? I said, I'm going home, I'm exhausted. He goes, why? So I'm tired. I was less than 36 hours. He goes, you'll sleep enough when you're dead. Go work out, go have a beer, go do something with your life for an hour, just 1 hour, and you'll feel better. And he's right. So I went out for an hour, and I worked my tail off, and I had this rush of adrenaline. I got home, started paying, I had a little bite to eat, started paying my bills, and literally passed out 20 minutes later. But I felt great because I had an hour of exercise. I was exhausted. Now, the workout rules now are a little bit easier, but I would say you'll have more time to work out than I ever did. Stay in shape. Don't eat all the free food they give you. Most residents gain about 20, 30 pounds. If you're like most of my residents now, I have 10 orthopedic residents and 24 family medicine residents. And, the ones that exercise and restrict their food intake don't get chubby, and the other ones all get chubby, and they all look different in 3 years. So get some sleep, always exercise, watch what you eat. The next question. Anywhere from an hour to a few hours after exercise, I become stiff and fatigued, almost drugged. Do you know what causes this or what to prevent? Okay, so what happens is after you work out, you release what I call your happy hormones, and endorphins and enkephalins. These are natural painkillers. And anybody that's been an avid runner gets a runner's high. You feel phenomenal. You feel invincible, okay? There's a reason for that, because it really hurts to run. And if you're being, when God created us, if you're being chased by a saber-toothed tiger, you better know how to run. If you don't, if your little toe starts hurting, guess what? You're dinner. So you had the body would release these painkillers so you could run away from the saber-toothed tiger. Well, with exercise, whether it's swimming, I've been able to achieve that with swimming, running, cycling, lifting weights. You just have to figure out how, what you do. Now, as we age, you're going to tighten up, but for an hour or two afterwards, you have those endorphins, so you'll feel good. But with EDS, you're going to have reflexes tightening. Okay, some of that's good. Okay, some of it's not good. It's okay to be a little bit tight every once in a while because, let's face it, some of us are really loosey-goosey. When you get older, that tightness feels a lot like arthritis because we do have arthritis earlier than others. The drugs feeling, that may be the endorphins and enkephalins. This is from Catherine, sorry. Pam, do you think males do better at strengthening because of male muscle mass versus female? Yes, I do. Remember, our bones, the osteoporosis we get, okay, and I've been a strength athlete for 20-some-odd years, okay? Do you think my bone density would be normal? Absolutely not. I've got osteopenia. And I lift weights. I've lifted weights. I couldn't figure out what it was. My vitamin D level was fine. What it is my joints are too springy, okay? My joints are too springy because my laxity, even though I load the joints with squats and deadlifts, the joints are a little springy, so I wasn't getting that piezoelectric effect. Okay, so I had to change some of my workouts to load that. Now with women, they're a little bit more springy because of the estrogen before they go through menopause. So that adds to it, and also the muscle mass. But I think women do very well with strength training because if they're not used to it, they'll get more bang for their buck than the guys do. So I do believe that. What is proprioceptive retraining? This is after you've sprained an ankle, you've torn the Golgi tendon apparatus in the tendon, and what that is you need to retrain those nerve endings so they fire before there's injury in that ligament, like in the ankle. So proprioception means balance. So it's balance training. So, like Karate Kid, where Mr. Miyagi's got Ralph Macchio standing on one leg with his arms up in the air. Try doing that. That's balance training, okay? The ankle is going nuts because it's trying to fire so the little Ralph Macchio doesn't fall off the pylon. Okay, here we go. Next question. It's a long one from Liz. I have POTS for about 2 years, just diagnosed hypermobility last Friday. Okay, welcome to the family. There's many of us. Okay, Dr. Serena, here's some neurons. How many patients with EDS have this abnormality? Lots. Okay. Do you have any recommendations with POTS and EDS? I've got tons of recommendations. First, you got to make sure there's a lot of cool ways to treat POTS. I'll just go over for those that don't know what POTS is, which is postural orthostatic tachycardic syndrome. Basically, you stand up quickly, you get all fuzzy-wuzzy in the eyeballs and feel like you're going to faint. Your heart jacks up, and that's the tachycardic, and you feel not good. You move quickly, so when you change positions, heart rate goes up because your blood pressure goes down. Why does our blood pressure go down? Because our veins in our legs and lower body do not constrict as quickly as someone with good vessels. Okay, now not that our vessels are bad, it's just they don't constrict as quickly because of the collagen. Okay, so if you can stand up quick, all that blood rushes to your feet, doesn't go to your what? Heart or brain. The brain doesn't like it. You get woozy. Heart doesn't like it. It jacks up the heart rate to make up for the low blood pressure. So the thick equation, which is heart rate equals stroke volume times cardiac output. So yes, there's simple things with increasing salt in diet and some other things, compression hose, but that's what I would do. And believe it or not, those that exercise, POTS gets better. It's one of the best treatments, but it takes time. None of these things I'm talking about happen overnight. It takes 6 to 12 months to see the benefit. It's not the McDonald's, go through the drive-thru, get the pill, slap on the patch, and off we go, we're good. That's what most doctors want to do. My buy-in is it's going to take 6 to 12 months of hard work. You're going to come out the other side better. Okay, next question from Kay. I have a hard time doing my exercises given to me by my OT and PT. I do not know if I'm doing them correctly when I'm home due to poor proprioception. Okay, good question. There's times that I hurt myself when doing exercise supposed to help me. What do you suggest I do? As I have a hard time communicating with the therapist. Okay, grab your smartphone, take a video, send it to Snapchat it, Instagram it, Twitter it, email it, whatever you have to your therapist. Say, I'm going to try this at home. If I have a problem, can I email you a video of me doing it? Or I would say most good therapists will say, yes, send it to this account or that. And they can tell you what you're doing wrong. Okay, so that's what I would do there. Okay. Another question from Pam. Non-exercise question. Do other countries tend to use the old nosology with numbers? I see this in forms. Yes, they do. It drives me crazy, especially all the work we did at the Bill France conference and to get away from the numbers. It is so confusing. And I know EDS, you got the Roman numeral types for the types of collagen and Roman numeral different types for the nosology or the classification. It's just, and I've actually seen people regress more and more back to the numbers, and I'm hoping with the upcoming conference that they're going to have in New York we'll put that to rest and get rid of that and publish some new data points, I'm hoping. Next question, are there any particular exercise regimens you recommend? Well, yeah, that was most of my earlier discussion points on like strength training and swimming. The object is variability. The object is you got to do balance, cardio, and strength with a focus on strength as the foundation. Every person's different. All of you are going to have different restrictions and requirements. We just have to be adaptive and having a good team of therapists that understand how to, when they hit a roadblock, go a different direction. That's the big thing with EDS. Lots of roadblocks. Some clinicians, doctors and PTs, chiropractors, stop at the first roadblock. I pile through, go around another way, figure it out. It just takes patience to get through those roadblocks. Damerholz suggests Pilates and yoga, particular weightlifting regimens from McKinsey. Any of those are good as long as you're not going to overextend. You get strength out of it, balance. Pilates, PRX, P90X maybe not the best for some people. TRX, suspension training, body weight stuff, all good. What would you recommend for a 3-year-old with EDS and Chiari, decompressed tether cord? We moved her from ballet and gymnastics. She's taking swim lessons 1 time a week. We live in St. Joseph, Michigan. Have not been able to find a knowledgeable physician. Should she be in PT this young? If so, how frequently? Okay, Jennifer, St. Joe, Michigan, I'm familiar with. I'm going to give some names over that you can check with. Heidi Collins is at Beacon in South Bend. She's a physical medicine rehab. She's the current head of EDNF, Professional Advisory Council. She will be very helpful. There's a Terry Olson in South Bend that I think is phenomenal when it comes to the treatment protocol, and he's independent, but there. 3-year-old, I let 3-year-olds be 3-year-olds. They're going to be naturally active. I have a niece who's 6 who's had a very arduous life with a congenital heart defect, and she spent the first 9 months of her life in pediatric ICU, cardiothoracic ICU at Hopkins, and we just let her be. Let her kids be kids as much as they can be. The ballet and gymnastics, I'm not worried about that at an age of 3 from an EDS standpoint. Now, Chiari is a little bit different, depending, and especially tethered cord. I'd be a little more concerned about head injury in gymnastics from that. But other than that, you need that kids to be kids. If you fawn over them, they end up being psychological cripples. They start to believe that they're different. You got to let them go. You got to let them be kids. Safely, of course, Jennifer, safely, of course. But my overbearing parents, which there's many out there, I have this big discussion that, you're going to put a bubble around your kid and they're going to be perfect and they're never going to leave your house. Okay? They're never going to socialize like other kids. I said, I thank God for every scar that I have on my body. Every single scar meant I did something. I was trying to be normal. Okay? And I'm an ugly son of a gun. Anybody that's seen me, I've got scars over 90% of my body. Okay? I would not change any one of those scars for the experiences that I got from getting those scars. And I'm not a sadist, please. Anybody can add. I was a firefighter. I was a barber. I was an EMT, paramedic. I've done things in my life that probably weren't the best choices, but have helped me become a better person. Okay, scars are just temporary. Dislocations are temporary. It's the heart and the soul that you need to, protect. What does your monthly clinic involve, Terry? Well, I actually see patients once a week that in my primary care practice, and I just try to coordinate their care with their primary care, where they come from. And I have patients coming from all over the world. Are there doctors? Lana Marie asked, are there doctors that do what you do in Ontario, Canada? I wish I could answer yes to that. I would go to the EDNF Professional Advisory Council and see if they have anybody in Canada. I can honestly tell you there's not a lot of us out there that feel truly comfortable, that doctors feel truly comfortable with EDS. They're out there and they're growing, and we're trying to educate lots of them. I do not know anybody in Ontario. I apologize. Okay, next is a long one from Susan. I'm in my 60s. I do cardio workouts, heart rate going up to 170s. I used to run marathons in my 30s. Now I ride a recumbent bike. I have pain. My pain is at the level that I moan and nauseated. I cannot handle going outdoors unless I have compression garments and a neck brace on. I'm bone on bone. Arthritis everywhere. Okay, so this is what happens to those of us that are very active. Eventually, you wear whatever little cartilage God gave you, and you're bone on bone. And you pay the piper one way or the other. Susan, my heart goes out to you. Your pain seems pretty significant. We need to help get you hooked up with a PM&R doctor in your area that can help you with some different things with pain control. I applaud you for staying active. Continue not giving up, trying different exercises. Keep doing that, because I think you'll find that if you don't do them, your pain amplification will get worse. So even though you're uncomfortable, staying fit is going to keep other things away like diabetes, hypertension, and keep you moving. I've heard from several, this is from Donna, I've heard from several EDS experts recommending not using resistance bands, TheraBands, or doing yoga. Do you recommend this? And why are we hearing opposing recommendations? I don't know. I use that stuff. It's cheap. It's inexpensive. People can do it in their homes, especially those with limited motion and limited funding. They can't afford gyms. So I think they're worried that they're going to do something wrong. But if you educate your patients correctly, you have good communication with them, that should not be an issue. So I don't know where that's coming from, Donna. Stacy, thank you. You said, I used to be a gym rat. I've had multiple surgeries of sidelined me for over a year now. I've lost all my muscle tone. How do you start exercising to know when exercise is too much and if pain is okay? Okay, Stacy, I'm going to tell you my story because a year ago I started on a journey of getting all my fingers fixed. I ended up having 6 surgeries on my hands. Now you can imagine I make my living using my hands, among other things. I did not work out outside of walking, I couldn't swim because I had pins sticking out of my fingers. I had one finger amputated, and it was a tough road. And I'm not quite back to where I used to be pre-surgery, but, you just got to just do it. Get back in the gym. As hard as it is to do the things you used to do, you may be able to lift 50 pounds, now you're down to 5 pounds. Well, guess what, honey? You just got to do it. You just got to get in there and say, what? It feels silly that I'll be 90-year-old and moving 10-pound dumbbells and I can't even use a 5. You got to start somewhere and build yourself back up. It's a long road, but you will thank me a year from now. Okay, you just got to do it. It will come back. It will take time. I don't know how old you are, if you're diabetic and other things, but you just got to keep putting one foot in front. Half the challenge they say going to the gym is just getting there. Once you're there, it doesn't make a difference really what you do. Just do something. Move your body. Do whatever you can. Find something that doesn't hurt that day and work it. Okay, next question from a male. It says, I am male. Thank you, I am male. If a male has EDS, if a male with EDS has problems adding muscle mass and fitness, routine, diet are okay. Why and what to do about it? Well, it depends on your age. It depends. If you're older, you may have low testosterone, low T. I'm not a big fan. Obviously, when I work with high-level athletes, professional athletes, I don't recommend testosterone. Have I used that for a few patients with low T with EDS where I know I need to get their muscle mass increased? Yes. So, I'm not advocating use of anabolics, but like I tell people, I can get 400-pound people down to 150, and I can get 150-pound people up to 250. It's all a game. How much calories in, how much calories out, burned out, you're burning, and you just got to get, if it sounds like your diet's okay, what's your protein? Are you getting enough protein? Are you getting all your protein on the front end of the day and not spreading it out? You can only absorb 20 grams of protein per sitting. If you're getting 50 grams of protein in breakfast and nothing later, you got a protein imbalance. Okay? So, scrutinizing the diet is important, scrutinizing your exercise regimen, making sure that your strength training is enough to build your muscle. Eccentric exercises will strengthen your tendons and increase muscle mass quicker. Okay. Francesco, I would like to know your take on whether the difference between hypermobility syndrome and EDS hypermobility type. My GP and rheumatologist think so. There is something in back UK. Okay. Francisco, you touched on something that I'm very passionate about. I actually wrote a letter to the editor for the British Medical Journal about 5 years ago on how I think it's hogwash that hypermobility syndrome is used by rheumatologists and the EDS hypermobility. If you look at the nosology, they stole everything from EDNF. It's the same exact condition. They use the Beighton scale. We've been using our criteria since 1971, and they just came up with this stuff like 10 years later. So, I just think they're just calling. If you look at the CPT codes and ICD-9 codes, the ICD-9 and ICD-10 codes, they're the same. So if their codes are the same, then it's the same thing. It's just called something different. Tomato, tomato. So that's my 2 cents on it. I never use hypermobility syndrome. I just say you've got EDS hypermobile type. Next question is from Fran. I have surgery coming up for an excisional biopsy with general anesthesia. First of all, if it's an excisional superficial biopsy, maybe you can get a local or, a block. That's what I do in my office. What should my surgeon anesthesia know about as classical? Well, Grant, if you got classical, you got stretchy skin, how you close wounds. If we're talking about excisional biopsy for skin, or if it's like you're talking biopsy for, a polyp, in your colon, that's a little bit different. That's a tough question to answer, so I apologize. Chris, about swimming, I noticed you mentioned both do and don't. Clarify. I get pain in my shoulders when I swim, even when I move in the water. Okay, if you're getting pain in your shoulders, there's pain and then there's dislocating. Okay, I've always had pain in my shoulders. Okay, but I didn't let that stop me. You got to get strong, and if you don't get strong, you're going to have pain in that joint. So you have some choices. If you can't swim, get in the water and move your arms. Literally stand in the water up to your shoulders and move your arms back and forth. And so you do that. It may take weeks until you can move your arms without pain. Then you can maybe use a kickboard. Okay, do laps with a kickboard if it's your shoulders that hurt. You can float with a noodle and just move your elbows a little bit. Okay, you just have to be creative. You don't have to be a competitive swimmer like Michael Phelps. You just have to move. Okay, however you do that, water is great because it's buoyant and not as hard as pounding at the joint. Next question. Lauren asks, how do you respond to doctors who say EDS does not cause pain, it's really fibromyalgia? Well, it's very simple. EDS does cause pain, and so does fibromyalgia, but they're totally two different things. Fibromyalgia hurts in the muscles. EDS doesn't hurt in the muscles. It hurts in the tendons and ligaments and joints. If you have pain in your muscles, it's either from lifting too hard that day or overdoing it that day, or you may have fibromyalgia. And fibromyalgia, you have 11 of the 16 pressure points, with about 5 pounds of pressure pushing on them. If you push on the, you have 5 out of 16 pressure points are positive, that's not fibromyalgia. You need 11 out of 16. That's the diagnostic criteria. And I'll just discuss with the doctor going, okay, you're wrong. It's this or it's that. And you can have both. I've seen many patients with both, but they're not as many as they used. Okay, pre-pregnancy. I love this. Dina is calling in. I love this pregnancy question. Pre-pregnancy, I was in excellent shape. I was a black belt martial artist, well-trained, weight-trained. I had problems with dysautonomy and dislocations prior to pregnancy. But after pregnancy, dysautonomy became much worse. What are your suggestions for exercising dysautonomy? You got to be safe first. Stuff like clean and jerk, snatch. You don't want heavy weight overhead if you're getting all whoopty and lightheaded. Excuse me. So you want to do some things like you want to make sure what your blood pressure is. Your blood pressure after you've had a baby can be really low because you're still third spacing from all the increased intravascular volume. So, we have to check blood pressure, see how that's doing. Are you breastfeeding? That can sometimes go into the mix. Not saying that breastfeeding will cause it, but it will cause increased volume, and sometimes I'll see it worse with breastfeeding. So if you're not breastfeeding and baby's a little bit older, you got to lose your baby fat, and you're diet and exercise. What exercising? I'm big into the safety of start off simple with resistant body weight stuff in a place that if you fell or got lightheaded, you wouldn't hurt yourself. Pools are pretty good because you're buoyant and it has a compressive effect on the legs and body, so you don't get as much of the symptoms when you're floating in water because the water compresses your legs, so that's helpful. So maybe water is the way to go. Let's see. That was from Deanna. Okay. Charlene, I know Charlene. And what are your thoughts on cyclobenzaphine flexion for spasm? It's a great medicine for spasm if they happen frequently. I imagine too much could be detrimental to building muscle. And cyclobenzaphine has been shown to be detrimental to muscles. Actually, it degrades. Okay, if you want to know, cyclobenzaphine degrades to a tricyclic antidepressant. Okay, which we know helps with chronic pain. So many times that drug helps with chronic pain because it actually degrades to amitriptyline or nortriptyline. So let's see. Sometimes sometimes it's so painful it doesn't let up with the heat, especially after exercise when trying to rest. Right, okay, so I think you're fine using FlexRoom. P.S. I have POTS anonymous. Name from Stacy, let's see. Please address exercise with POTS dysautonomia. This is a problem because it's exercise that will make it better, but it's also exercise initially that makes it so hard to deal with. You feel like throwing up, your heart's racing. So you have to start very slowly. You have to start with things that are not going to trigger your dysautonomia. It may be walking. Whatever your triggers, you have to figure out what your triggers that gets your heart rate jacked and your blood pressure to drop. And then you realize that, and then we have to start doing a sort of like desensitization to that exercise, especially if it's something you want to do. Let's say it's running or a sport that you like. So we'll work with our therapists to desensitize them. So let's say your thing's running and you start to run and you just it's horrible for your POTS. Well, we don't start you off running, we'll start you off walking. Very slowly on the treadmill. How do you feel good? Okay, you feel good. Well, we slowly bring them up. We find out at 4.2 miles an hour on the treadmill is where they start really feeling the symptoms. Well, we'll keep them at 4 miles an hour and jump them up to 4.3 for 15 seconds and then back down to 4. Okay? Then we'll do that a couple of times, a couple of days, maybe a week or so. Then we're jumping up to 4.1 miles an hour. We're going up to 4.5 miles an hour. Eventually, the body acclimatizes. Everything acclimatizes if you tease it just ever so gently. And, of course, hydrate, avoid certain types of supplements, things like that. This is from Taryn. My 9-year-old granddaughter diagnosed with classical ADS, fragile skin, any recommendation protective gear. They allow her to present other than swimming. She does not like swimming. Well, she's 9. And, when you're 9 and you got classical type and you got scars and you're a girl, it's going to be tough. You don't want people to see your scars. Yep. Back in the 70s, I remember my mom, God rest her soul, she would make she'd take soccer shin guards and take off the plastic and just the pad and make these little pouches in my knee for my knee pads, and I'd wear shin guards under my very long knee-high socks in the 70s. So I had knee pads and shin guards, and I always wore high tops because people would step on my heels and revolve the skin under my heels. So I have very fragile skin. So a lot of protective, clothing, that is protective of the shearing forces on classical EDS. Okay. What is your take on the use of human growth hormone in EDS? In my review of the literature, I could get my hands on, there was little evidence for it being very effective in lessening the effects of faulty collagen. Correct. If you make, just like with testosterone, what does testosterone do? It makes more muscle and can weaken the tendons. That was part of my research at Penn State. Human growth hormone is going to grow muscle and tendon, but you're also growing abnormal tendon. So there is a risk for that. I do not use human growth hormone in my patients' EDS. I have an 11-year-old, this is from Kelly. My 11-year-old daughter recently diagnosed with EDS, hypermobile type. She is strength training with her trainer and taking physical therapy twice a week on top of being a competitive dancer. There we go. Extremely careful to avoid stretching and overreaching. She is now stronger than ever. We keep hearing about hormones make EDS symptoms worse as she goes through puberty. Yeah, you haven't even gotten close to the of things that, so I've been warned that she may need to stop dance even though she has zero pain now. Stop. Well, okay, she's danced. Do not recommend, first of all, she is a competitive dancer because she's got EDS, I'll be honest with you. I see them at the other end when their body's destroyed by 18, 19 years of age. Competitive dance is competitive dance. It takes a toll on the body. There's a lot of jumping and leaping. She's fine now. I would be very, very cautious, Kelly. I hope if she's doing ballet, she's 11, she's still a little young enough to be on point, if you would ask me. Ballet is the most stressful, and gymnastics and cheer are the most stressful in the joints. Mostly it's gymnastics and ballet. If she's in hip hop, maybe a little bit better. Jazz dance, a little bit better. She needs to continue to strength train with her trainer. But realize you're in therapy already. And she's 11 years old. She's in therapy. You have a trainer, and she's kind of a dancer. You're spending a lot of money on a kid for something that you need to be very careful with. I've taken care of the Philadelphia Ballet and Southhold Ballet. I've very flexible women. EDS, you start off good, but the longevity's not there as a career. So you want to start planting the seeds of alternative exercise and sport, because if she gets a big injury, and I hope she doesn't, you're going to be very happy that you have a backup sport or backup condition thing for her. Next question is from Deanna, from Susan. I'm in my 60s, cardio workout, heart rate in the 70s. Okay, we already answered that one. We already did that. What type of daily diet do you suggest with various exercise you suggested? Okay, this is from Jonathan. John, it depends on your age. I'm a protein, high fiber type of guy, fresh fruits and vegetables as much as possible, whole grains. Probably no different than most of you. Avoid junk food when you can. Small portion sizes, believe it or not, everybody overeats in America, and myself included. Limit your sweets as much as you can to only a couple times a week. That's very commonsensical things, and everybody's going to be different. I have everyone do diet logs for a week. Meet with my nutritionist. I use myfitnesspal.com on the smartphone for my patients so I can actually see what they eat. Most people are very poor historians. We all underestimate what we eat. If I followed you guys around in the office, if you were in an office, all the different foods and snacks that people have, it doesn't even register that people eat those things. I've been mostly afraid to exercise since having surgery in my severe pelvic organ prolapse at 28, 2 years ago. How do you suggest managing significant risk of recurrent prolapse with the need to exercise? You bring up a great point, and this is called fear. And fear paralyzes many people. If you were active before, you'll be active again. If you've never been active and you've had these issues, the fear may be even more overwhelming because you've never known what it's like to feel strong and feel good. And you can do this with EDS. You definitely can. So, once again, I go back to things that are not going to increase your intra-abdominal pressure. If you're overweight, we need to lose that weight. My skinny minis and my overweight patients do horrible with EDS. I'll just be straight up with you. As an ex-obese person myself, okay, when I was overweight, everything hurt. And I gave every excuse in the book. Guess what? Stop the eating volume. Get off the couch and move. If you can, you can walk, hopefully. You can swim, hopefully. Or have access to it. You can cycle. These things will not increase the pelvic prolapse, I hope, depending on what they did. But you need to do something, because doing nothing at the age of 30 is not an option. Not an option that I would want to deal with. We got to get you active. You can do arm curls. You can do military press. If it's just your pelvic organs that are a problem, we just got to find out what we can get you to do. Good question by Jonathan Rodas. How do we help our children coping with pain? How do we help our children cope with pain? Well, you know what? Example. If you have EDS, they're going to see you. Just how you live your life is the best example. My oldest son has EDS. And he doesn't have it, as much as I do, and he's adopted, so he doesn't even have the same genetic type I have. But he sees it. I don't let it slow me down. I go to bed at midnight, and I get up at 4:30 in the morning. I work out. I swam 1.5 miles this morning and walked on the treadmill just before this conference. I do 2 a day. Why? Because I know what's going to keep me moving. So love them, love your children, help them, teach them that pain is temporary, that you love them, and teach them how to cope with that pain. The next question, in addition to EDS, I have a history of spontaneous rib fractures. Very interesting. Are there any types of exercise I should avoid? Yeah, boxing, MMA, and martial arts. Not good for you, Renee. And I mean that in jest, but I just covered boxing at the United States Naval Academy last weekend, and we didn't have any rib fractures, but if you're getting spontaneous rib fractures, I would really get yourself checked out for osteoporosis, osteopenia. I'd look at, are you coughing? Do you have asthma? Is there something putting stress on your fracture, on your ribs that we don't know about? Christy asked a question. Any commentary on being reliably injured by PT and exercise? Injury, not pain from work. Thanks. Okay. Yeah, I've had stories where PTs have caused patients to have pain or worsen their condition. Some of that is usually just PTs not educated in how to deal with EDS. I just joined a very large healthcare system that spans 4 different counties and has cared for over 2 million lives. And I'm educating my PTs here, and I've got a handful that I know that I've taken to Greater Baltimore Medical Center for an EDS conference that I know they know how to handle it. Let's see. Okay, my last question is regarding hip resurfacing procedures as opposed to replacement on patients' EDS. Is this procedure safe? There's one last thing. Well, hip resurfacing obviously is a segue. You can always get a hip replacement later. Obviously, if you've got arthritis, the less you do, the better. I would maximize range of motion of that hip, weight loss, strength around the hip, and psoas, cortisone injection, anything I can. Once that has all been exhausted, along with PT, hip resurfacing is an option. You have to make sure you go to get a clinician familiar with EDS so they do low insufflation pressures. That's how much the pressure they put into the joint to distend it. Because if they put too much pressure, A, they're going to rupture the capsule when they resurface it, and B, that capsule does provide some support. And they sort of have to sort of auto-dislocate the hips to do this. So if you've stretched out the capsule and the ligaments and teres, you'd be at higher risk of dislocation. Okay, next question is for Suzette. My 13-year-old has hypermobile type, continually injures ankles and wrists. In gym class, are there better exercises for her to do rather than team sports? All classes in gym have to do modified or adaptive PE, so absolutely, she needs to be involved with gym. It's going to keep her from getting overweight, which is going to be very much worse for your granddaughter, especially if she's going through puberty. So there are other exercises. Yeah, core strengthening exercises. Go back to my PowerPoint and see some of the different strength things and cardio things that I mentioned there. And they probably can adapt their class to that. Okay, Kay asked a question, interesting question here. I control a lot of pain by deep breathing. Very good. I wonder, though, if this is raising my adrenaline and if I'm overtaxing my adrenal gland. I end up pushing through the pain and find out days, weeks, months, if not years later, I broke a bone. Comment. I think deep breathing is pretty safe. Now, I haven't heard you deep breathe. I occasionally get those phone calls, of deep breathing, but that's not the type of deep breathing exercises you're talking about. The interesting thing is, I would say, in your case, I don't think you're taxing your adrenals. I would beg to differ. See, you've got osteoporosis from another cause, and that's what's causing the fractures that you're talking about. Keep up the good work. Keep exercising. Okay. What 3 things would you recommend we bring to our caregivers to help them improve our quality of life, not only with not only pain but understanding EDS? Okay, John, this is from Jonathan. 3 things. I included a pamphlet on EDS that I wrote for EDNF back in 2005, 2006. Download that and show that to them. I did write an article I made available on current sports medicine reports called EDS and Athletes, and the other, so that those are available. I made available to John and Deanne. I think they probably say some things. The other thing is, movement, exercise is medicine. There's a poster out there that shows 100 positive benefits of exercise, from improvement of depression and relationships, body weight, mobility, all the sorts of different things. So helping partner with no physician really wants to put their patients on chronic narcotics. it's sort of like a cop-out. We feel as physicians we're copping out. It's sort of, it's sort of universal. We'll do it when we push to it, when someone comes in already on narcotics. But, it's easy to write for a narcotic, but we know that they're going to become tolerant and dependent, and we know it's going to be a tough life for them if we ever try to take it off it. So if you go into your doctor's office and say, I want you to partner with me and help me find a good PT, a great exercise physiologist, help me exercise so I don't need to take narcotics, 9 times out of 10 your physicians are like, yes, I like this patient, I get it. If you walk in and say, I've tried exercise and PT and they all suck and I just want my pills, they're going to be like, okay, here you go, and they're not going to be engaged with you. So that engagement, 2 different ways to approach a caregiver, might get a better benefit. Can you suggest good resources for physical therapists in EDS? I wish I could, Dina. I don't know where you're located. The APTA, American Association, the American Physical Therapists Association, APTA, the website, www.apta.org, may have some resources there. I would also go to EDNF website and look at their professional advisory council. Terry Olson is the one in South Bend. Perry Tallman is here in New York. Those are my go-to people here locally. There's some people in Baltimore that are really excellent in D.C. So hopefully that's helpful. I'm 34 years old. This is from Lauren. Diagnosed with type 1 type 10 years ago. In the last year, I've torn my jaw, spontaneous eruption, cervical disc, requiring fusion. Fingers and hands flare, typing is painful. I have chronic fatigue, which is debilitating. I've tried to get into a routine with exercise, swimming, but then I decline so much that I can't function. What do you recommend? Lauren, it's very simple. Don't give up, okay? You got to keep going. You got to make sure you're eating and sleeping, and you got to keep exercising. Because when you give up and stop moving, just pick up your hover around, just pick up your wheelchair, if you need that strength. I can't tell you. And everybody's different. This is tough. You've been dealing with this for 10 years. But as someone that's a little bit older than you, that has everything that you're talking about, I know if I go 3 days without exercise, I'm useless. So I work out every day, sometimes twice a day. It's my own physical therapy to keep myself going. So I'm going to encourage you, Lauren, to keep going. Okay, Ashley, right? I'm participating in the leaving protocol for POTS dysautonomia. Cardiac reconditioning with strength training. Bada bing, bada boom. That's what I'm talking about here. Piggybacking on previous questions regarding the rebound tightness post-exercise a couple hours later, I found that a twofold approach for stretching has been helpful. My self-guided approach has been light stretching immediately after the workout, yes, then later doing some mild, deeper stretches like child's pose. Is this a good approach? Absolutely, Ashley. Thank you for sharing this with us. This is exactly what I'm talking about. We get really, all that happy hormones get us nice and loose. We're improving our POTS, but then afterwards you tighten up, and it happens. What I call it, you start gelling. You sit down, watch a little TV, half an hour, you can barely get out of the chair. Okay, while you're in that chair, stretch, 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 okay? 41-year-old with very athletic female diagnosed with EDS, sudden yet severe decline in last year, resulting in trip visits to the Mayo Clinic with EDS. My muscles seem to be disintegrating. Went from 103. See, here we go. Here's my classic skinny mini versus my overweight person. 113, 97 pounds. So that's very, very low body weight, and that just makes things worse. There's no muscle mass to support the joint. I'm extreme amount of neurogenic pain with fasciculation. Neurogenic pain is not EDS. There's something else going on here. Extreme joint laxity of late. Difficulty time walking, like I have MS. Is there MS? No. Here's the thing. Just because you're struck by lightning doesn't mean you can't be run over by a truck. Just because you have EDS doesn't mean you can't get MS and all these other beautiful things. It sounds like you've got something else going on here other than EDS. So once again, I don't diagnose over the internet, but that would be something I would look into. Your concern, flare-ups, what does that mean? A flare-up is people with EDS, they can, when you get older, you can tell you're like a human barometer. You can tell the weather's going to change. Flare-ups will be anywhere from a couple days to a couple months where your joints just are screaming at you. And, it's a lot more achy and painful, and then they get better. And we don't know why. But those are the flare-ups we're talking about. That's for Jennifer. Can you recommend a doctor or therapist in the Chicago area other than Brad Tinkle? Okay, there you go. I was going to say Brad moved from Cincinnati to Chicago. Let's see. This is for Sue. A doctor in Chicago. Carrie Jaworski. C-A-R-R-I-E, Jaworski, J-O-W-O-R-S-K-I. Tell her Mark Lavallee sent you. She can call me. She's very, very good. She's musculoskeletal family medicine. She would be that. As a therapist, I don't have any therapists in that area. Did you say not Pilates? I didn't say anything about Pilates for EDS patients. I think Pilates is fine. It's done correctly. Dietary change of supplements. I'm not a supplement person. I think that most of them are hogwash. I've had to work with the supplement industry. They're generally crooked, and the stuff they put in them get my athletes popped for all sorts of substances that they didn't know they were taking. So I think the supplements need to be regulated. I just tell you, eat a healthy diet. If you eat, green leafy vegetables, high fiber, enough protein, you don't need half the stuff that they try to sell you. Collagen, no, yes, it's a collagen problem. Taking collagen by mouth just is a protein source. Your body breaks it down to amino acids, and that's all it's used for. It doesn't help your collagen. Do you recommend compression garments or support joints during exercise? Yeah, sure. I mean, if it's not going to hurt you, and if you get you to be active, absolutely go for it. Okay, next question from Sue. My insurance company states it will not allow me to have PT visits beyond my 8 visits as my condition use makes it unlikely to make progress will be made, short time frame, will not be covered. How do I get medical well to see ongoing therapy that changes? You know what? Here's what you do. Insurance companies like that, you can go through the realm of your typical realm of negotiating and battling them, or you can do something novel. Go to a therapist and say, here's the deal. I have 8 visits. This is what you're going to get. I would like to make a deal with you. And you may have to pay for it out of pocket, but you strike, a lot of these places, a lot of PTs are still mom and pop places. And if you say, I will pay you $20 a visit out of my own pocket, or $10 or whatever, and if you could just guide me, you get me set up on a couple machines, and analyze me once a month. I'll pay a little bit more for that analyzation, but I want to use your gym and your ultrasound machine. I bet you most of them would. It's either you're not going to. They know you at that point. They don't have to do much, and it gives you access to them. Yeah, it's out of pocket, but you know what? Think about the time and money you're spending battling with the insurance company. Maybe it's just easier not to go out to dinner 3 times in a month and use that money to pay for your physical therapist or something. I don't know. There's just some unique things I've had patients do. Rebecca asked about a question about aqua jogging didn't trigger my POTS, and there's a lot of that. Yeah, absolutely. Aqua jogging is awesome. I put on my people without EDS that have stress fractures in aqua jogging. Remember, as you're in the water, your feet are about 6 feet down because of the compressive effect, and that pressure, which is about 100 millibars, is going to keep that blood and shunt it up to your brain and your heart. So this aqua jogging is awesome. Keep up the good work, Rebecca. I appreciate the example of moving your arms in the pool if you cannot swim yet. Could you address how to stay active, but be smart about it? For example, if your fitness level is to walk in the pool for 10 minutes, start with that and work gradually up to do more. How to respect your limits, not injure yourself, halting, forward progress. Can you give some examples how less fit EDS can start? Okay, here's the thing. For my overweight or my chubby EDSers, I love water for one reason. Fat floats. Okay, I'll say it again. Fat floats. It's very hard to sink an overweight EDS patient. Okay, because they float. Okay, I just put them in the water, give them a noodle, and say, move stuff. I don't care. Move it for 5 minutes. Move it so it doesn't hurt. And then next time we'll do it for 10 minutes. I don't care what you do. Move your arms and legs. Okay, just float around. Then I'll get them buying in that they can walk without pain. They'll get a pair of sneakers, walk on the bottom with your sneakers on, and walk from one side to the other. That's resistance. Believe that's resistance training. Walking through the air is easy. Walking through water is hard. So, you listen to your body. Get a water. We use a lot of water therapy in my practice, so that's where I start there. Next question, Amy. I'm in my 30s, early 30s, in my teens and 20s. I used to be a distance runner, training, running 5Ks, half marathons. I had trouble with my ankles since I was a kid. I had several years of running experience. Here we go. Now I've had my ankle surgery, and I know you said long distance is not great for you, yes, but I missed it a lot. It's very addictive. Running is the most addictive sport that I deal with. Tell a runner not to run, and they leave your office. They go see someone else. So I get everyone. What about short distances? 1 mile, 5K, non-competitive. Okay, Amy, here's the thing. You need to number one, you've already had ankle surgery, so we've already broken your body down. I'd have to look at your biomechanics of your feet, because if it's too off, you may be 30, but by 40 you'll have an ankle fusion and you're never running again. You're never running down the street with your grandchildren or your older kids. So I'd be very cautious about what activities you do. I don't mean to scare you, but I get people at the end of the rope from all over the country, like they were this, that, or the other thing, and they want to get back to it. So for my runners, I get them hooked into distance swimming, because you get the same runner's high in swimming. I get them into strength training, not at competitive, of course, but short distances, yes, you can do that. But remember, your ankles and your knees, you only have so much tread. You've already started to wear some of that out. So you have to go, would I rather run 1 mile 3 times a week for the rest of my life, or run a 5K, every month for the next 2 years and never run again? You have to pick, because you only have so much tread left. But I think elliptical is great. Some steppers, you won't hurt your joints, and you can get some of that happy hormones going. Lisa asks a question. I've been working a lot with a foam roller, because I really have tight muscles. I've noticed when I get knots, my joints move better. When I get the knots out, my joints move better. But I feel a lot more unstable, and they're prone to sublux. Does muscle tightness actually serve an adaptive purpose? Yeah, it does. I mean, the tightness and spasm is because your joint laxity, the body's trying to tighten up that joint. So you work out some of the tightness, and the muscles feel better, but you may have a little laxity. But over time, what will happen, if you keep up with it, the tendons will start thickening up, and those tendons and ligaments around those joints will become secondary stabilizers. Thank you, Lauren. Lisa. Can you recommend a doctor in South Florida? Yeah, South Florida. I've got one of my fellows who's in North Florida. Okay, in Mid-Florida in Gainesville, I've got Jay Clugston, Clougston. He's with the University of Florida. Evan Peck, Evan Peck, Peck. He's in Northern Florida. I don't have anybody that I know really well off the top of my head in Southern Florida. Great talk. Can you recommend doctors or physical therapists in the New York metro area? Yes. Brian Halpern at HALPERN, Hospital for Special Surgeries. You can tell him I sent you. He's downtown. Westchester and Fairfield. Sorry, dude. There's only like about 10 of us that do this on a regular basis, and you're going to have to travel. Most people travel to see people, many states over to get expert advice. Last question was, thank you, okay, sounds like I've answered all the questions. With that stated, it's 10 minutes after 9. I want to thank you all for listening to me babble on for way too long. I hope I did not offend anybody. That was not my goal. My goal is to share with you my journey as a patient with EDS and as a clinician. Thank you.
Thank you, Dr. Lavallee. I think a lot of people are receiving a good dose of hope and encouragement and motivation from what you accomplished and from the success of your patients. And I know each journey is individual, and some people you have to start where you're at, fitness-wise. So I appreciate you, tackling that, because it's hard, there's no one size fits all. But everybody's got to move and do what they can, start where they can, and build upon that is the message I'm getting.
Yeah. It was, I recognized some of the names that were attending tonight, which is nice. I think you guys are doing a great service. I enjoyed it. It was, I've never done one of these before. I enjoyed it tremendously. So maybe down the road, if you need another speaker, maybe I can, if you want me back, I'll be more than happy to help out.
We would love to have you back. Yes, thank you.
I've got other topics like EDS and pregnancy or female issues with EDS and some other talks that I can talk about.
Great. Thank you so much.
Okay, take care. Bye-bye.
Yeah, we really appreciate your call tonight. And I'd like to remind people that we will be having our calls every first and third Tuesday. So the next call will be on March 17th. So you'll be seeing those announcements on our website. Also, the recording for this particular call and the slides and a few other links that and documents that the doctor provided us will be on our site. So again, if you're in the U.S., please visit our website, our store, bodysupportstore.com, where you'll find over 250 products that are selected by EDSers for EDSers, various braces and pillows and carts and other helpful products, and that's what supports this program. So please go out and look at the products that we sell. So I appreciate everyone being with us, and particularly Doctor, this has been a very, very informative talk tonight, and we certainly appreciate you joining us. So we're going to call it an evening. So thank you very much for joining.
Thank you, everyone. Good night.
Bye.
Night.